I'd like to now introduce Dr. Erwin Montgomery. He is a movement disorder neurologist and a neurophysiologist for nearly 40 years at many major medical universities. Currently, he is a professor of neurology in the Department of Medicine at McMaster University and the medical director of the Greenville Neuromodulation Center, a nonprofit biotechnology corporation in Pennsylvania, USA. He has published over 100 papers on Parkinson's disease, basal ganglia physiology and pathophysiology, deep brain stimulation, and 7 books, most recently, Medical Reasoning, The Nature and Use of Medical Knowledge, and Reproducibility in Medical Research, Biomedical Research, Epistemological and Statistical Problems. Dr. Montgomery is going to be speaking about Parkinson's disease after the honeymoon phase, how to identify and manage motor complications. Thank you, Dr. Montgomery.
Well, good afternoon. It's a pleasure to be here. I do have to explain, I've had a lot of trouble with my knee, and this knee decided to show me who's boss. There was a valuable lesson in it, over 30 years ago. I let my then 10-year-old son convince me to take judo lessons with him. So this is a very late complication of an early sports injury. But I'm very, very grateful to be here, so thank you very much to the organizing committee, and particularly to Dr. Barbara Conley for the kind invitation to talk to you. And I always like talking to the Parkinson's community because I owe them a huge debt of gratitude that I have not yet completely repaid. Over the many years, I've done a lot of research with patients with Parkinson's disease. They've been incredibly kind and supportive. They've done things in my research projects that I'm not sure I would have done. So I'm thanking all of you on their behalf for the tremendous support that I and other researchers have gotten from the Parkinson community. So thank you all very much. So I'm going to be talking today about, let me just go on here a little bit. Just in the way of disclosures, I do receive royalties from a number of books that I've published related to Parkinson's disease in medicine and research in general. I have a number of patents for which I receive royalty payments for those patents dealing with statistics and mathematics. I do consult for FHC, which is a corporation that makes equipment and supplies for intraoperative monitoring of patients during deep brain stimulation surgery. As I had mentioned earlier this morning, I vouch for no spelling or grammar. I have terrible dyslexia, so do forgive me for that. So as was mentioned, I'm going to talk about what happens after the honeymoon period. And truly in Parkinson's disease, it is amazing. There is this early in the disease where patients respond so beautifully to the medication. I swear sometimes you just show them the bottle of the carbidopa levodopa and they get better. And what happens, though, is that over the years, the disease changes and the way the patient responds to the medications, to the treatment, changes. So it's always a moving target. And so we're always having to adjust medications. As the question was made today about whether or not your medications have been stable for 6 months, that's very difficult to say in Parkinson's disease. But what your physician should do for you is to get a letter for the insurance company saying, my disease has been stable for 6 months, even if my medicines have not. And so make that clear distinction. For example, there are a lot of people who have diabetes who administer insulin on a changing scale, depending on how much they eat, what their blood sugars are. You wouldn't hold that against them in terms of going out of the country. So I am not Canadian. I'm a Canadian wannabe, but I'm here in Canada because my wife is Canadian and she was from this area. And so after about 30 years of marriage, she said, I'm moving to Canada. I'm going to become the new assistant dean for speech-language pathology at McMaster University, and you can tag along if you want. So here I am. But it has been an extraordinary privilege for me to be practicing for these last couple of years here in Canada and comparing it to my experience in the United States. And it's been very interesting. And in many ways, things are so much better here, and in some ways there are some difficulties, but you all know that far better than I do. But I do have to permit me just one observation. In the 2 years that I've been practicing here in Canada, I have never had a patient come to me and say, and worry about personal financial bankruptcy because of healthcare costs. I have never heard that here. But yes, I hear it all the time in the United States. So you all are to be extraordinarily congratulated on the wisdom of providing care to all citizens of Canada. That is an extraordinary accomplishment. So coming here gave me a chance to kind of compare how I was doing things in the United States and my colleagues in the United States compared a little bit here in Canada. And so there have been some interesting observations that I've made. So after I had been here for a year or so, I went back and looked at the data from my patients that I saw in the clinic in my first 6 months. And so I wanted to see, well, how are the patients that I saw in my clinic, how are they being treated compared to my experience and the experiences elsewhere, okay? Now, this is not to say good or bad or anything, but there are some differences. And I think in understanding those differences, examining those differences, maybe we can come to a better overall solution. Well, one thing I found was that I said, well, the patients that are coming in and they're on levodopa, what's the total amount of medicines that they received during the day? What was their total dose during the day? And so you can see here on the blue bars, this shows the dosing of the patients on levodopa. And the blue here shows my experiences in the clinic. Now I'm comparing that to the dosing of levodopa in clinical trials. So in one study where patients were randomized to deep brain stimulation and other patients were randomized to best medical therapy, what was the dose of levodopa under the best medical therapy by the best experts in the world? And those are shown in orange. And you can see Parkinson patients that I saw in my clinic coming to me were on much, much less levodopa than patients in best medical therapy in clinical trials. So the most common dose was around 400 milligrams of levodopa per day. In the clinical trials, the average dose was 1,700 milligrams per day, or 17 tablets of the 25-100s, for example. So there's a huge difference there in terms of the amount of levodopa that is used. Also, I looked at how frequently were the patients getting their dose of medication. And what I found was that the most common dose was 3 times a day or 4 times a day. Okay? So if you have a patient who has what we call a long duration response, that may be fine. So this graph here shows the levodopa getting into the bloodstream and then the levodopa going out. Okay, so the medicine gets in and then the medicine is gotten rid of. And then on this top graph here, you show the patient's symptoms. The patient's getting better and then gets worse. So what you'll see, though, is even as the blood levels of the levodopa are going down, the patient is going up, doing better. Okay? So that's what we call a long-duration responder. You can contrast that then with this patient. So here you can see the blood levels go up, the patient gets better. Blood levels go down, the patient gets worse. This is what we call a short-duration responder. So the long-duration responder may do well. 3 times a day, 4 times a day dosing, okay? Here you can see that the patient's symptoms are still better 3 hours after the dose and still doing better 5 and 6 hours after the dose. But then the short duration responders, you see, they get better. It takes a couple hours for the medicine to get into their system, and you can see just within a couple of hours they're getting very much worse. That kind of patient is not going to do well on a 3 times a day schedule or 4 times a day schedule. The problem for the physician first seeing a patient is they can't know if the patient is going to be a long duration responder or whether the patient is going to be a short duration responder. And so you have to do things to try to understand how long does it take for the medicine to get into the system and how long does it last for that individual patient so that you can adjust the dose of the medication. This is shown fairly dramatically in this slide. So here again is a study where a patient is given multiple doses of the carbidopa levodopa through the day. And the patient takes a dose, the levels get up, go up in the bloodstream, the patient's finger tapping, slowness of movement gets better, the patient's walking gets a lot better, but then you can see that the blood levels are starting to fall before the patient takes their next dose of medicine. So as the blood levels are falling, the finger tapping, the slowness is getting worse, the walking is getting worse. So this patient is a short duration responder. Worse than that, you see, is that when the levodopa is highest in the bloodstream, the patient's having dyskinesia, the involuntary movements, what I call the Michael J. Fox Foundation, where you've seen videos of Michael J. Fox, how he's having all these writhing movements. And so you can see the patient's blood level, because the patient's taking these tablets of carbidopa levodopa, the blood levels are going up and down, up and down. As the blood levels go up and down, their clinical control goes up and down, and their involuntary movements get worse, better, okay? Now here's the thing, you take that same patient and you put them on a constant infusion of levodopa, where you put the levodopa in the vein, and you can see how dramatically better the patient gets and how the patient stays good. So the critical issue for us is keeping these medicines in the brain at a constant level so as the patients are under good control through the whole day. That's very, very difficult to do with medications because you give a pill, it goes up and down, up and down, up and down. But it's impractical to give it through the vein because it's not very soluble. But that's why Dr. Conley and other doctors are now using a constant infusion of levodopa, not through the vein, but through a gel that goes into the stomach. And so that's one way to to smooth out these fluctuations, okay? Now, the problem is patients are complicated, and they may have, and for many patients, no 2 days are exactly the same. So it's very hard sometimes to figure out how long does the medicine last for, how long does it take to get into the system. So in many places, many areas of expert areas develop what I call our all-day evaluation program. So a patient will come in and spend the entire day with us, and then every hour on the hour, they're evaluated by a physical therapist or a nurse, and we get a graph of exactly how their symptoms are doing through the entire day. I can look at that graph and I can say, okay, we need to increase that dose, we need to decrease that dose, we need to move this dose over here, we need to move that dose over there. And then oftentimes we can get the patient under very good control. We also do this for other things too, for example, like anxiety. If somebody's anxiety is related to the dosing of the medication, well, we examine their anxiety every hour through the day. And at the end of the day, we can get a pretty good idea whether or not it's related at all to the medications. If it is related to the medications, how we can adjust that then to get rid of that problem. So here we call that our all-day evaluation. The Mayo Clinic calls it their Parkinson profile. Almost everybody calls it a different name, but the fundamental thing is you need to know precisely how the patient is responding to the medication if you're going to make a difference for these patients who have more advanced disease. Now, you'll notice I say here, if we put them on a constant infusion of levodopa, so we're putting the levodopa in the vein and keeping those blood levels in the blood levels constant, which makes the brain levels constant, the patient does much better. Except there's a couple noticeable differences. Here, there's a drop-off, improvement in the dyskinesia, but some worsening of the finger tapping, even though the blood levels are the same. Here's a dramatic reduction, dramatic fall off in the walking, and a dramatic worsening of their finger tapping, slowness of movement. But the blood levels are about the same. And if you look carefully, it would say high protein meal. Okay? So the levodopa has to be transported from the gut into the blood and from the blood into the brain. There's an enzyme, like a ticket taker, that pulls the levodopa in from the gut into the blood and from the blood into the brain. Okay, so this is an enzyme that carries the levodopa molecule into the brain. That same transport system, that same ticket taker, also transports large neutral amino acids from protein. So when you eat a protein, it's broken down into these amino acids. These amino acids then compete with the levodopa. And if there's just a lot more amino acids, the levodopa is not going to get in. So there are some patients that do know that if they eat a large protein meal, they turn off. And so there are things we can do to adjust the protein so as to minimize that effect. Also, levodopa is complicated because there's only a very small part of the intestine where levodopa is absorbed. It's absorbed in what we call the distal jejunum, a small part just in the small intestine. So there's only a length of about a foot or so that can absorb the levodopa. And that means then if you take levodopa with a meal, the first thing that happens when you eat is there's a little valve at the end of the stomach called the pylorus. It closes right off. And if your pill happens to be sitting in the stomach, when that pylorus closes off, it ain't going to get to the jejunum. So there is very clear evidence that taking levodopa with meals will delay absorption by about a half hour to an hour, and it reduces the amount that's absorbed. So that's scientific evidence that levodopa should be taken on an empty stomach. Now, we always have the problem with nausea and vomiting. In fact, it's interesting, in the old days, I can remember this before carbidopa, if a patient wasn't vomiting at your feet, they probably weren't taking the medicine. And so there was the introduction in North America of carbidopa, and in Europe of medicine called bensericide, so they're used in combination. In fact, the name Sinemet, that name was coined from sine emet, that means without vomiting. Okay? So if patients usually now don't have too much trouble with vomiting, but for those that do, just giving a little bit of extra carbidopa can block the nausea. Okay? There are other things that you can give to block the nausea. So you can still take the carbidopa levodopa on an empty stomach. You don't have to put up with nausea, and you don't have to give up regular absorption of the levodopa to get good clinical response. Okay? Now, I discovered just shortly that carbidopa is not available here in Canada. And it was also mentioned that Retori, which we'll talk about a little bit later, is not available here in Canada. But I just discovered recently that your physician can make an appeal to get you that medicine. So there are mechanisms in place for Canadian citizens to get access to certain treatments that may not be widely used or widely released here in Canada. So there are those opportunities. So as you can see, during the honeymoon period, where the brain response is for hours and hours and hours, even though it's gone from the blood, those patients are pretty easy to treat. But when that brain can't store that dopamine, then it's going to get harder and harder. And the medicines last for shorter and shorter periods of time. And so there are various ways then to make the levodopa work better. And so this is another set of curves. And this shows, again, the person takes the medication here, measures how much is in the bloodstream, and how long it lasts for. And so at this bottom curve here, that's just plain old immediate release carbidopa levodopa. You can see it lasts the least long compared to these other medications. And then there's what is called controlled release carbidopa levodopa, lasts longer. You can take controlled release carbidopa levodopa, add it to a medicine called entacapone, which reduces the breakdown of the levodopa, and you can make it last longer. And then here is what is called Retari, which is a combination of fast-acting and slow-acting carbidopa levodopa. So parts of the pills are shaped very small and absorbed rapidly. Then there are larger pills that are absorbed at later periods of the time. And you can see then it lasts a lot longer in the bloodstream. Okay, so there are techniques, there are methods that can be used to prolong the effect of the levodopa, so there's not this up and down, up and down, up and down. Now, you can see here that controlled release carbidopa levodopa has significant advantages, at least theoretically. It lasts much longer. It lasts much longer in the blood than does the immediate release carbidopa levodopa. Okay, so that's a significant advantage. But there is a disadvantage to the controlled release carbidopa levodopa. And the reason why is that pill is designed to slowly release in the GI system. Okay? So you can imagine an immediate release carbidopa levodopa getting into the jejunum, dissolving rapidly, being rapidly absorbed, and about 99% of the levodopa from the immediate release gets in. So now you get this pill that's designed to dissolve over 4 to 6 hours. So if it goes through the jejunum too quickly, If it goes past that part of the small intestine where it's absorbed and the pill hasn't dissolved, it ain't going to work, okay? And so one of the problems is that everybody's GI tract moves at a different speed. And so if you have a patient that has what we call a very fast GI transit time, where the pill whisks by, well, it's not going to dissolve and it's not going to be absorbed. So that's a problem, okay? And it turns out that about 4 out of 10 patients who take carbidopa-levodopa controlled release do find that it's not dependable. And that may be relating to just how fast it's getting through the small intestine. But 6 out of 10 are doing well with the controlled release carbidopa-levodopa. So if a physician says, man, I'm just never going to use controlled release carbidopa-levodopa because not 100% of my patients get that kind of response, well, I have to question the logic of that. You know, if you're one out of the 6 out of 10 that gets a good response, then what does it matter about the other 4? I mean, it's unfortunate for the other 4, but if you're doing well, why not? So again, this just shows what happens. Again, you take a pill, the blood levels rise, and then they start to fall. And so we say, okay, how long does it take for half of the levodopa to be gone from the blood? Okay, and that's what we call our half-life. And so here you can see the half-life of levodopa in this experiment was about 2 hours. Now I'm going to contrast that then with pramipexole, a dopamine agonist. And the beauty about the dopamine agonists is they get into the brain, they don't have to be converted to dopamine. Also, the dopamine agonists can be absorbed anywhere in the GI tract, anywhere in the small intestine. And so here you can see then both, you take a pill at this time 0, gets into the bloodstream, and you can see how long it's lasting in the bloodstream compared to immediate release carbidopa-levodopa. Okay? So patients that are going up and down because the levodopa is going up and down, the pramipexole is a significant advantage. Okay, so we do tend to see this kind of natural history we see in Parkinson's disease. And let me just back up one moment. We had made incredible advances in the treatment of Parkinson's disease. I started my medical training when we only had levodopa and acetylcholine, artane, cogentin, those kinds of things. And then while I was a resident, we had the introduction of bromocriptine and then carbidopa-levodopa. It is amazing the progress that we have made, amazing. And I dare say most patients will do well for many, many years. In fact, I have some patients who are doing so well after 10, 15 years, you'd be hard-pressed to say that they had Parkinson's disease when they're being treated properly. So again, I want to encourage you, one of the worst things I see happening for patients is when they and their doctor give up too soon, okay? So, but there is this history of the disease that we have to deal with, and a lot of times we can work around those changes. So for example, early on, patient is not fluctuating, not going up and down, is not having the involuntary movements, and they get good sleep benefit. They wake up, they're doing great. And what that tells you is there's still some dopamine neurons still left in their brain that can store up the dopamine, and when they wake up in the morning, it can now be active. After a few hours in the morning, they get worse. Then you get to a point where they lose that sleep benefit, and now they're starting to develop the motor fluctuations, turning off quickly. Then they start to develop dyskinesias, and some patients can get to a situation where when the blood levels get to a certain point, they start to have side effects before they ever get benefit. And those can be very difficult patients to treat, but we do have treatments for those patients, like deep brain stimulation surgery. So why does this happen? This cartoon here shows you a dopamine neuron, okay? And this dopamine neuron is making contact with this neuron in the part of the brain called the striatum. And this is the normal situation. So the dopamine neuron here releases dopamine. That dopamine goes across the gap and stimulates the postsynaptic neurons, and now you can behave, you can move normally, okay? And then once the dopamine is released, two things can happen to it. One is the dopamine gets chewed up and spit out by this enzyme called COMT. More often, though, the dopamine is taken back up into that neuron and saved for a later day. That's why patients who are asleep, they can take that dopamine back up and store it there. And then many patients, when you give them levodopa, it gets into the brain to create dopamine. That dopamine can stimulate the neuron here to get the benefit, but that dopamine now that came from the levodopa goes back into the few remaining dopamine cells. And that's why they can respond to the medicine for hours, even though it's not in the bloodstream anymore. But as the disease progresses, you don't have those neurons anymore. And now the rest of the brain depends on what's coming from the blood. Blood goes up, their dopamine goes up. Blood goes down, their dopamine goes down. Okay. And so this translates over time into patients early with the disease. They respond well, they don't have involuntary movements, and the benefit lasts a long time. And then what happens here, the benefit gets shorter and shorter, and more dyskinesia. Okay, so in part, this is related to the natural history of the disease. This is what's going to happen to any Parkinson patient. But we have to ask ourselves, is there some aspect of that that is because of what we're doing? And if it's because of what we're doing, can we prevent that in any way? And as Benjamin Franklin said, an ounce of prevention is worth a pound of cure. And so is there some way we can do that? So one of the concerns was whether or not levodopa was toxic. And that notion of toxicity is a confusion. Okay, does it kill brain cells? No, we don't think so. But it doesn't have to kill brain cells to cause toxicity. It doesn't have to kill brain cells to cause problems. Okay? And so one of the big problems we find is these motor fluctuations, on-off or wearing-off effect, and the involuntary movements. So in one study that was done, they took newly diagnosed early Parkinson patients. They rolled the dice. Half of them got levodopa, half of them got pramipexole. And they say, well, what happened over the years? And here you can see by the end of 5 years, the patient with levodopa had a much higher risk of having these complications, much higher risk than patients that were just on pramipexole. So if you look here then at dyskinesias, involuntary movements, again, those patients who started on pramipexole had less than half the risk than the people who were started on levodopa. Okay. Well, you'd say, oh, levodopa, pramipexole obviously has an advantage. The same was true with ropinirole. But then people said, well, the reason why is because levodopa is more potent. You overtreated the patients with levodopa. Of course, they're going to have problems. That's why they had more trouble than pramipexole. But that's not true. I mean, the physicians, the patients didn't know what medicine they were getting, and the doctors that were treating them didn't know. It wasn't until after the study that they found yet, oh yes, the levodopa appears to be better on the part of the test, part of the Unified Parkinson's Disease Rating Scale, the motor exam. Yeah, there is a difference. The patients on levodopa are doing better than the patients on pramipexole on this test. But if you say, what's the quality of life? What you see is that there is no difference in the quality of life for the first 2 years between patients on levodopa and patients on pramipexole. So even though there may be some difference in some of the motor symptoms on the testing, if you look at activities of daily living, virtually no difference. If you look at quality of life, virtually no difference for the first 2 years. So I think most of you would probably put more emphasis on your quality of life than the motor test of the Unified Parkinson's Disease Rating Scale. So as we can see, huge problems, but levodopa is a godsend, and I would not want people to walk away with the idea that levodopa is a bad drug. No, okay? It's like saying a sledgehammer is a bad hammer. Well, if you need a sledgehammer is a good hammer, okay? So levodopa is very important. And thank God we have it. Just about every patient with Parkinson's disease on levodopa is going to need levodopa at some time. But to the point where we can lower the levodopa exposure, delay the levodopa exposure without qualifying quality of life, without diminishing quality of life, to me that sounds like a good thing. So again, levodopa is a critical medicine, and it is a godsend to the Parkinson community, but we need to use it wisely. Now, there are situations then where even in the best of hands, the medicines are not going to give the patient the quality of life that they want. So we do have an alternative, and that is deep brain stimulation. And deep brain stimulation involves implanting electrodes into various targets in the brain. The electrode then exits through a small hole in the skull that's tunneled underneath the skin to a little stimulator device that's implanted in the chest. And that provides a little electrical stimulation to the brain. It is amazing. We have no idea how it works, but it's amazing. Okay? And so there have actually been studies where patients were, a number of Parkinson patients in more advanced disease, moderate to advanced disease, they rolled the dice. Half the patients got deep brain stimulation. Half the patients got the best medical therapy in the hands of the best experts in the world. And at the end of 6 months, the patients with deep brain stimulation are doing far better than the patients on medications. No question about it. Medications are good for about 2 to 4 years before the symptoms get back to the way the original were before medicines. With deep brain stimulation, there's continued benefit for many of the symptoms for years. But deep brain stimulation has risks. There's about a 2 out of 100, 3 out of 100 chance of a serious complication. And about 1 out of 1,000 are going to die from the surgery. So the question that every patient has to answer is an 80% improvement in my tremor, an 80% improvement in my involuntary movements, a 70% improvement in my speed of movement, is a 50% improvement in my walking and balance. Is that worth taking a 2 to 3 out of 100 chance of a serious complication? Ultimately, that's the decision that only the patient and the family member can make. But you can only make that decision if you're provided an opportunity to make that decision. If your physicians don't talk to you about DBS, you don't have access to DBS, that question becomes academic. I'm sorry. So thank you very much for your attention. And again, I want to thank Dr. Connolly and the organizers for the opportunity to be here to talk to you this afternoon. And I guess we have some time for a question or two. And I do apologize, my hearing is very poor, too much rock and roll music growing up, so I'm going to ask Dr. Connolly to maybe repeat the questions for me if I can't get them.
Can we get a written copy of what you've just given?
Parkinson, there is a website that you can go to for the presentation. I don't think we have any paper copies here, but at the bottom of the schedule, there is the website where you can obtain the copy of the presentation.
So wow, that was a lot of really good information, a lot. So I don't even know what question I really have, other than the fact that absolutely it seems like it's just up and down, roller coaster all the time. And you go from this to that, and nothing really seems, you're kind of hopeful and it works and then it doesn't. And so we've never had that opportunity where what you were talking about, going into a clinic and evaluating, you know, the level of the levodopa. And so how do we get involved in that? Like, because our doctor isn't doing that. You know, and we're from Niagara, and so we have a doctor in Toronto. I would prefer to come here closer to home in Hamilton, but you know, how do we get involved in something like that? Do we leave one doctor to go to another? Like, these are all questions that we're just not sure what to do, and we're worried, you know. And are doctors in Hamilton area accepting new patients? That's another question.
So the question related to the Allday evaluation and access and things like that? Yeah. Okay. So, first of all, when you're addressing the issues about this up and down, up and down, up and down, there are a number of things you need to address, and that can be fairly simple. Does it seem to happen after meals? Or does it seem to be associated with meals? Maybe the meals are delaying the absorption. Is it related to protein intake? Is the patient getting worse after scrambled eggs and cheese? So that's a different thing that we would approach. A big issue is, are they taking their medicines consistently? Okay? I know myself, I'm only good for about 50% of my medication doses. Okay? And I always say that one learns more from error than from chaos. So if you're not taking the medicines on a regular basis, on a precise schedule, it's chaos. We're not going to be able to figure out what's going on. But if you take the medicines precisely at the times instructed, we're going to know if it's going to work or not work. So those are some of the things that you do immediately. But then you get to situations where you're not quite sure. So over the years, I've developed a number of questions I ask the patient to get a sense of how they're responding to their medication. So I'll say, when do you know what time it is to take your medicine? When do you know when you're supposed to take your medicine? If a patient says, oh, I start shaking like crazy, all right, clearly we're dealing with wearing off. Clearly we're dealing with wearing off. If they say, I look at my watch, well, that tells me that they're not wearing off, okay? And so that tells me maybe the dosing interval is the right dosing interval, okay? So those are some of the kinds of questions that we can ask. And then when those kinds of things fail, at the Hamilton General, we have been doing these all-day evaluations. They're, as you can appreciate, time demanding. I would try to do them myself and often wind up tripping over myself, but it is doable. And then Christine, the nurse practitioner in the movement disorders program, she's been helping doing these all-day evaluations. So technically they're not hard to do, they just take a bit of time and they take some commitment. But I can tell you it is amazing how much insight you can get from doing this all-day evaluation. I can see if this is, so when we look at these, we see a number of different patterns. We see what is called peak dose dyskinesia. We see what are called wearing off effect. We can see what we call a loading dose effect. We can see what we call an accumulation effect. All of this from looking at the graphs over the day in the clinic. And those, when we see those kinds of things, we know exactly what to do with the medications. Sometimes we'll see the all-day evaluation and we'll say, hey, there's just no way the medicine's going to work. Let's move on to something like deep brain stimulation.
Hello. Question that may be totally crazy, but we're talking about Cinemet 100/25. We're talking about a Parkinson's patient that's taking, depending how good or bad it is, over the month, 6 to 8 pills during a day. It's a constant up and down. So the one question is, how much of that levodopa is being absorbed at the time? And the crazy question I'm asking is, can you take that 100/25 and cut it into 4, and over the period of the 3 hours, ingest a quarter of a pill to try and level the ups and downs out?
Right. So that's you really hit on the problem, particularly in moderate and advanced Parkinson's disease. What we call the plasma kinetics, how the medicine is handled in the blood becomes very difficult, very complicated, and it's going up and down, up and down. One way to treat that is by taking a medicine that lasts longer, over a longer period of time, like controlled release, like Ritari, like the intraduodenal infusions of levodopa gel. That's one approach. Then you can also take a different approach. And a number of years ago, we used to do what we call our liquid Cinemet therapy. And for the liquid Cinemet therapy, a person would take the tablets of Cinemet, crush them up, put them in a container of water with some vitamin C to act like a preservative. And then every hour, they would sip the liquids. They'd shake it, then they'd sip the liquid Cinemet. If they were starting to have dyskinesias, they'd take a little bit less. If they were starting to turn off, they would take a little bit more. And so they were then able to adjust it themselves and keep reasonably good control. I had one patient, though, that was a failure. And so she was on the liquid Sinemet, and she was doing great. I saw her, I said, she's doing great. And she says, no. And I saw her a few weeks later, and she stopped it. And I said, you were doing great. Why did you stop it? Well, she would put her liquid Sinemet in a hip flask. And every hour, she's drinking from her hip flask. And everybody thought that she was nipping. So she gave it up. So that's one approach. Now, the liquid Sinemet can be very effective, but it is difficult to remember to take it every hour and to adjust it. That's a complicated process. Now, with the intraduodenal infusions of the levodopa gel, with the longer-acting medicines, with all the agonists that we now have available, and with deep brain stimulation that we now have available, that should be less of a problem.